Okay, this is going to be a quick run through for our bleeding chapter for AEMT. Most of this is going to be review from your EMT book, but there are a few things that we'll go a little more in depth in. We know that bleeding can be one of the most time-sensitive conditions. We have to find it early and control it as best we can, and it can cause weakness, shock, and even death. We know that our body relies on a process called perfusion, which is circulation of blood within an organ or tissue in adequate amounts. So basically what that means is that enough blood has to circulate to deliver an adequate amount of oxygen and nutrients to all the tissues in the body, which is in turn called perfusion. And you see them some listed there: the heart, the brain, spinal cord, the nervous system, the lungs, the kidneys. These are just some, but all tissues are included. The cardiac cycle, a couple of terms you need to know here. Obviously, it's a repetitive pumping process that circulates blood throughout our body, but you do need to be familiar with the term preload. That is the amount of blood returned to the heart waiting to be pumped out, or the pressure that the blood coming back through the inferior and superior vena cava. And afterload is the pressure in the aorta, or the peripheral vascular resistance. So basically, that's what the heart has to pump against. So if you had a blood pressure of 120 over 80, or 120 millimeters of mercury over 80 millimeters of mercury, that means that the heart has to pump greater than 80 millimeters of mercury in order to move any blood forward, because 80 millimeters of mercury would be the pressure in the vessels or in the aorta while it's at rest, or while the heart's at rest. So that's afterload, the pressure that the heart is pumping against, whereas preload is the pressure or the amount of blood that's returning to the heart to be pumped. And the cardiac cycle is connected to bleeding, obviously, because the cardiac cycle is what circulates blood throughout our body. Delivery of oxygen to our tissues is dependent on our heart working appropriately, having adequate stroke volume, making sure we have plenty of hemoglobin in place, and making sure that we have plenty of oxygen available to attach to that hemoglobin to be transported and dropped off in the tissues. So hemorrhage is a discharge of blood from the blood vessel. So anytime we are bleeding or blood is exiting the vasculature, then it's not inside the vessels of the heart. That's not where it needs to be, and that's considered hemorrhage. And a lot of times we can control it by something as simple as direct pressure, more pressure dressings. Sometimes we have to go all the way to the other end to wound packing or tourniquets, or using hemostatic impregnated dressings. So external hemorrhage comes from breaking the skin, okay, and its severity is basically how bad that break might be. Internal hemorrhage can happen in any part of the body. We usually associate major blood loss with our thoracic, abdominal, and pelvic cavities. Also, bilateral femur fractures. That those compartments can hold excessive amounts of blood. We do know that there's we think of hemorrhage being related to trauma, but there are lots of non-traumatic reasons. You could have GI bleeds or ectopic pregnancies, even ruptured aneurysms and such. So things that can cause internal bleeding could be anything from falls, blast injuries. Remember, because in blast injuries, we get a concussion wave that can damage internal organs without really creating a lot of external damage, that at least not damage that's not visible to us. Any kind of automobile crash or whatnot. And there are a lot of illnesses that can be associated. We just spoke about GI bleeds, which would be related to the bleeding ulcers or bleeding colon, and once again the ectopic pregnancies and aneurysms. Signs and symptoms of internal hemorrhaging are going to be typically pain at the site. Blood is an irritant. The body doesn't like it being out of the vascular container, so whenever it's outside of the container, it does irritate and causes pain. There can be swelling or bruising in the area. There can be a hematoma, or also hematemesis, which is the blood in vomit. all the way to your first signs of hypovolemic shock usually is going to be a change in mental status, feeling lightheaded. We've all stood up a little too quickly and our blood pressure hasn't been able to compensate, so we get a little lightheaded. The same with blood loss. Our body, there's not enough pressure there, and so our body, we start getting a little lightheaded or maybe a little altered. So substantial changes in vital signs can happen when just 1 liter of blood is lost. But our body automatically compensates by increasing our heart rate and our respiratory rate in order to try to maintain a blood pressure for as long as possible. Our body tries to save itself, tries to maintain that perfusion. But we know that bleeding is considered serious if there was a significant mechanism of injury or possibly the patient just has a poor appearance. Maybe there are signs of a shock already present, that altered mental status or pale, clammy skin, whatnot, or if we actually visually see rapid loss or we have some kind of bleeding that we can't control through our ordinary means. So how does our body respond to hemorrhaging? So bleeding usually stops pretty quickly. Okay, platelets are on site almost immediately, and they start to bind together to plug the hole, if you will. There are a lot of medications that interfere with normal clotting. If we have patients with any kind of cardiac issues or any history of blood clots, they may be on warfarin or Xarelto or some of the newer ones where these blood thinning medications that don't that prevent the clotting factor. Also, patients that are post-cardiac issue can be on a daily aspirin, and we know that aspirin inhibits platelet aggregation, and so therefore can make clotting more difficult, I should say. And also patients that have blood disorders like hemophilia, obviously they would be affected by hemorrhage also at a greater extent. Trauma triad of death. This is something you do need to know. You need to make sure you're aware that the trauma triad of death is a combination of hypothermia, coagulopathy, and acidosis. Okay, that is your trauma triad of death. You will see that again. Coagulopathy is the disruption of the body's ability to clot. Obviously, hypothermia is our body's core temperature going down, and acidosis is us retaining that hydrogen in form of carbonic acid or lactic acid or something along those lines. We already know how to size up a scene and do a primary survey. We're going to jump through that pretty quickly. Just remember that our primary assessment starts off with a full body scan, follow the XABC. That's X for exsanguination, or X to make sure that we control hemorrhage first as quickly as possible. Internal bleeding must be treated promptly, but remember you have to be aware of the signs and symptoms of internal bleeding because you're not seeing it externally. There's nothing in the pre-hospital setting that we can do to stop internal bleeding. However, treating for shock and rapid transport is going to be their best option because getting to surgery is going to provide the highest possibility of positive outcome. We know how to take histories. We know how to do secondary assessments. We know how to reassess critical patients every 5 minutes en route to the hospital. And we know that a reassessment involves the repeat of an entire primary assessment plus vital signs, plus reevaluation of any hemorrhage control measures we may have taken. External hemorrhaging can usually be managed with direct pressure, or sometimes we have to add a pressure dressing to it. Maybe we even add a splint on top of that. Air splints are prepackaged pressure dressings in themselves. And we'll talk about those in just a second. But we would provide high flow oxygen, assist ventilations if necessary. Any bulky dressings, remember once we start applying dressings to an external hemorrhage, we don't remove those dressings if the hemorrhage isn't controlled. To put on more, we just continue to pile more and more on because we don't want to disrupt any clotting that may have taken place with the initial dressings that we applied. Tourniquets, be familiar with how to use whatever your agency uses. There are a lot of different options out there. There's the CAT tourniquet, the Softy, the SWAT-T, there's the RAT tourniquet. There's several different ones that you made. There's Israeli, the ratcheting medical tourniquet. Lots of different ones out there. So just be familiar with what your agency uses. and how to apply it as quickly as possible. There's some examples of those. There's a cat tourniquet up there in the top left, the ratchet tourniquet there on the right-hand side. It was actually designed by someone who basically took a tourniquet or webbing and attached a inline skate ratchet to it to create that. It's really good for one-handed applications. So you typically are not going to release a tourniquet before you get to the hospital. It's going to be released at the hospital. If you don't have a commercial tourniquet available, you can use a triangular bandage. You see there how they tied a bandage around the arm above the side of the injury, tied a stick or windlass in place, and you're going to twist that and twist that and twist that until there's no set number of times. You're going to continue to turn it until the hemorrhage has subsided. There's those air splints or splints that we talked about earlier. Rigid splints can help stabilize fractures, but those air splints, they inflate and they can actually apply pressure to a dressing and slow circulation in the extremity to help with external hemorrhage. Excuse me. We have hemostatic agents out there, and basically what they do is they adhere to damaged tissue or dehydrate blood, causing it to clot more easily. They are usually pretty easy to remove from the wound, and they usually don't put anything into the rest of the body's systems as smaller particles or whatnot. Wound packing is one of the last efforts we make, but if we have injuries to the torso or even the upper part of the lower extremity that we cannot control with a tourniquet, we might have to do some wound packing, and that's basically where we continue to apply gauze inside the wound until we're able to apply pressure to the bottom of the wound where the hemorrhage is originating. Pneumatic anti-shock garments, or PASGs, you also see them written as MASS trousers. Military anti-shock trousers are basically Velcro pants. They have 2 leg compartments and an abdominal compartment, and they are inflated with pressure to push blood. They're originally designed to squeeze blood out of an extremity back into the torso to raise blood pressure, but when inflated to a certain amount, they can help with external hemorrhage as well. Anybody who's hemorrhaging from the nose, ears, or mouth, there are lots of different causes for this. Could be from a traumatic incident where they have a skull fracture, facial injuries, chronic sinus infections resulting, or even the overuse of nasal spray, or extremely dry sinuses. High blood pressure can cause nosebleeds, as some of the thinnest vessels in our body are located in our nose, and we can have coagulation disorders. Digital trauma is actually, we can cause nosebleeds by picking our nose, or a patient can, excessively. Epistaxis is the actual name for nosebleed. That's epistaxis. Be familiar with that, because that's how it will be referred to from here on out. And it can cause enough blood loss to send a patient into shock. However, maybe remember these are difficult bleeds to control because there's not external hemorrhage. The hemorrhage is coming from somewhere inside. So basically what we'll have to do is compress, apply compress, or press down on the bridge of the nose, having our patient lean forward. We don't want them swallowing a lot of blood. And another alternative would be to roll gauze and place it under the patient's upper lip, creating pressure in that nasal cavity to stop the hemorrhage from taking place. Internal hemorrhage, not really a lot we can do that other than rapid transport. We're not going to give the patient anything by mouth, but we're going to do our standard treatment for shock. We're going to keep a monitor on our vital signs, make sure we keep our patient warm. We'll apply or obtain IV access. In traumatic injuries, part of PHTLS, you'll see is that we're going to maintain blood pressures. We think of 90 being a normal blood pressure, and we think that we want to run fluid to get above that, but between 80 and 90 is adequate in traumatic events because it takes 80 millimeters of mercury in order to perfuse the brain. And that's our ultimate goal, is to make sure that our brain and vital organs are being perfused. We don't want to raise the blood pressure to a point that we actually increase hemorrhage or blow out clots that have already formed in our body, or our patient's body, I should say. Continually monitor its level of consciousness, pulse, and blood pressure, constantly reassessing. And that's going to be the end of our bleeding lecture.